A lovely welcome to our viewers. My name is Paulina Khmara and I am a student on a master's program in applied psychology. And today I'm joined by Lorna Staines, a PhD candidate in the Royal College of Surgeons in Ireland, who is going to talk to us on the topic of psychosis. So first of all, thank you so much, Lorna, for joining me today.
Happy to be here.
Would you like to start by giving our viewers an overview of your background, role, and your research?
Yeah, of course. So I'm a PhD student. I'm in my final, just coming into my final year now. My field is in early psychotic experiences. So I look at them before what you'd meet as a criteria of psychotic disorder. So what we're looking at is kind of preventative research. And my background, I went to Trinity College for my undergraduate, and then I did a master's by research in psychosis in Glasgow.
Thank you so much, Lorna. I was hoping that maybe we can start, if you could tell our viewers a little bit about psychosis. What is it and how does it manifest itself?
Yeah, of course. So I think what's probably worth noting is psychosis is quite a broad term. It describes a lot. It describes a loss of connection with reality for the individual. So probably the two most defining features of it are hallucinations, which are stimulations in any sensory organs that can be hearing things, seeing things without an external cause. So hearing a voice and the person isn't there, feeling something on your skin and there's no cause for it. The other part then would be delusions, which are very strongly held beliefs, which are outside a social norm. So the belief that people are constantly spying on you, the feeling that someone's watching you, the feeling that special voices, special messages are being left for you, anything like that. So they'd probably be the two defining features or symptoms of the condition. But it's a very broad spectrum. So you have people with psychotic disorder, and you also have people in the general population that I study, which have transient ones. So that's psychosis.
I see. So it is quite a big field there to cover. And in regards to prevalence rates, when it comes to psychosis, what are we looking at? And are there any cohorts that we might consider a higher risk of having symptoms?
Yeah, so prevalence of psychotic disorder is about 1%. So about 1 every 100 people have what we call a psychotic disorder, with the most known version of that, or type of that, as being schizophrenia. So that's psychotic disorder includes schizophrenia, but includes a couple of other conditions as well. So that's about 1% of the population. What I study, early psychosis, is much more common. So in adults, it's about 5 to 7% of adults will experience it. And in children, it can be as high as 17%. So it's not what we'd call we wouldn't say they have a psychotic disorder or even that they're necessarily going to develop one, but it's psychotic symptoms can be indications of mental health outside of the psychotic disorder as well. So that's kind of the prevalence rates.
That's very interesting. And also as well with children, it's an interesting one because obviously, it'll be hard as well to diagnose, I can imagine, because you don't know how much of it is maybe imagination or psychotic kind of episodes.
Yeah. Well, this is the interesting thing. For a long time, and there is still a problem in child psychiatry, people didn't think children had psychotic experiences, or they thought that it was a hyperactive imagination. What we'd probably mark as the important differences is one, the child doesn't have control over it. Children can have like a quite vivid imaginary friend, but an imaginary friend that they see even when they don't want to would be something you'd be worried about. Or the child could be worried about it. So the children themselves know the difference between play and imagination and this thing they didn't control happening. So it was originally thought to be pretty uncommon, and we actually now realize it's a really common symptom of distress in children.
Oh, that is extremely interesting. I did not know that. Thank you so much for that. I was also wondering if you are aware of any particular factors, maybe genetic or environmental, or perhaps both, that may increase the probability of psychosis or psychotic symptoms occurring.
So both, and again, while I'll talk between them, it's because there's a large overlap in them, and in fact, we think they're part of the one spectrum in the way that people might be familiar with autism having a spectrum now.
Yeah.
Similar ideas of psychosis, so we think it's a broad spectrum. So the risk factors overlap a lot. And there's significant genetic risk. This is studied mostly in psychotic disorder, and a lot of it is in psychotic disorder. If you have a close family relative who has psychosis or psychotic disorder, you have an increased risk. But there's also a lot of environmental factors. So these start in utero. So maternal drug use and smoking and drinking to some degree, maternal infection or birth complications, and then throughout a lifetime, things like trauma, bullying, abuse, environmental factors like pollution, all that kind of stuff can add together. So there's not a single cause to anyone, but it's a combination of a genetic vulnerability and the environmental factors tends to be what leads someone to a psychotic disorder.
Okay, I see. Yeah, that makes sense. Of course, there's a lot of factors that in general in relation to mental health which would have a
Yeah.
significant impact. And can you tell us as well, does research tell us anything about the relationship between psychosis and the brain, whether it's structural or neurochemical? A brief overview.
So there is a lot on it. There's actually a really strong amount of evidence that there's big changes in the brain when somebody experiences psychotic disorder. So if you're screening someone who has a psychotic disorder already, there'll be whole volume decreases, gray matter decreases, white matter decreases, the hippocampus and the prefrontal get changed, which are kind of areas to do with memory storage, and then the higher processing, kind of how you reason and goal direct. There's also changes in the auditory system, and there's evidence of this changing before they be considered full psychotic, like having a psychotic disorder. And in particular, there's a group called clinical high risk. So these are people who have pretty frequent hallucinations or delusions, but have an ability to doubt them is a major part of it, and don't have them so severely. So they're quite high risk. They'd be much closer to the threshold than them. And screening from those people to then who go on to have psychosis and what we call first episode psychosis, there's a massive change in their brain within a year, that kind of year of transition. So it's what's called the critical period,
Oh, wow.
which is thought to be a massive change, basically because if your reality is that someone is trying to hurt you all the time, you're in stress mode all the time. And people with full psychosis can't doubt that. That is their reality. So their brain responds to the stress, anxiety, as well as their brain causing hallucinations. So it's also changing in that way. So it's a double mix. There's quite a lot on it, but we're not clear fully on the mechanisms of it yet, or which is important. Like, does it matter that the prefrontal is changing, or is the prefrontal causing the change?
I understand. Okay, that's quite interesting. And in regards to assessment and diagnosis then, is there a specific protocol? What would that look like?
So it will depend again on where the person is, like what kind of frequency they're experiencing the symptoms, how severe are the symptoms, how much do they believe the symptoms. So there's kind of how much can they doubt them. So as a general rule, if you were to be experiencing them, like reason for it would be a good idea to go to see your GP, because earlier intervention is the way to do it. It's the way the sooner you can get help for. But what would generally speaking happen, assuming you are someone with a psychotic disorder, you'd be referred from a GP to a psychiatrist, and they would formally diagnose you. Because you would, assuming you're having hallucinations or delusions, you might well be put on a medication like an antipsychotic, which helps you manage the symptoms. And similarly, the psychiatrist would have better training in what sorts of interventions or therapies might work best for you. So the diagnosis will be done by a clinician. There are tools to diagnose it, but it would also be done at an interview based. So seeing what the person has, and the big things I've said it before, like the frequency they have them at, frequency they have at, the severity of them. That is, do they feel like someone's watching them? Can they see someone watching them? Is it someone they can't shake? Like they can very visibly give details about how they look, for example, of hallucination. And then the conviction of that. So that is, do they have an idea that this isn't real, or are they struggling to understand that that's not real, which is a kind of very classic sign of psychotic disorder, is that inability to tell it's no longer real, so that loss of reality. And then distress would be another thing we check about when we're assessing the psychotic disorder, is how upsetting, how distressing is it to the person who's experiencing them. So this would be what you take into factor, and it'd be a psychiatrist normally who would diagnose that.
Okay, and you mentioned medication, but also other kinds of therapies or interventions. What kind of other types of interventions may be recommended to someone experiencing those symptoms?
So this it's a really broad spectrum, so it depends where you're talking, but to focus on psychotic disorder, because I say it's what more people are familiar with, it depends on how the person's doing. The first thing to do would be to try and help them with dealing with their symptoms. So that's what the medication would be involved in. The next part would be what's called symptom management. This can be clinician-led or peer-led, but it's a way for it to help the person sometimes come to terms with having the symptoms, sometimes learn that they aren't real, or learn mechanisms to cope with it. And following that, there's a lot of different things. I know so they sometimes do CBT, which is cognitive behavioral therapy, which is a way of trying to help you restructure your thought processes. That can be particularly like if somebody has a paranoid delusion, so they're quite scared all the time, trying to help them develop mechanisms to be like, you often feel like you keep thinking people are following you. Develop a mechanism whereby they can take a step back and think about, is it likely this is happening, or what's my safety mechanisms for it? And the longer term interventions can be often like social and occupational, because it's very debilitating to have a psychotic disorder. Like during a psychotic episode, it can be very debilitating to your physical and mental health combined. So a lot of it can be about getting back into work, learning social skills again, learning supports and cares, that kind of thing. So it'll be a long process, particularly for someone with psychotic disorder, and it'll be an ongoing process. But there's a lot of different interventions that we use, and they can be quite effective.
Okay, that's great to know. And also that just popped into my head while I was thinking there and listening to you. In regards to family support, I would imagine that probably involving the family members would be quite a very good move towards actual recovery, to have them kind of get involved and understand, and perhaps even help them identify, especially if they're having trouble with knowing when things occur.
There'll be a few kind of different family interventions. One, it's for them themselves. It can be very difficult to have someone, like often people with psychosis can be very healthy until they're about 22, 23. Like there's people who show earlier symptoms. It's not a guarantee. And then your child becomes very, very sick very suddenly, or your partner needs a lot of support. So you do family interventions aimed to support the caregivers. Then there's exactly what you say, education and trying to help the person with it. There's also family group therapies and that kind of thing, which is to work on like plans together about how you'll do it. Because while you can abstractly, I can design the best occupational therapy in the world, if it doesn't apply to the person's life, it's not relevant.
Of course.
So there's a lot, and there's a big push now to try and integrate more into the family, because the families are really essential to how care happens for any patient in any context, but particularly in something like this.
Of course, yes. And environment, once again, crucial to everything in regards to mental health. Just kind of close it off, I wanted to find out on a personal level and as a researcher, do you feel that there are any misconceptions surrounding the topic of psychosis and the psychotic disorder that would need to be addressed?
I think so. I don't know if all of it can be research based. I think a lot of it is general information based. I think it's so one is, while TV shows now always go, oh, schizophrenics always hurt themselves more than others, they never show them in that reality. They show the murderer who is schizophrenic, or they're always put in that context. And while they shows have a habit of acknowledging that most people with schizophrenia or psychotic disorder don't hurt people, they very rarely show that. And I do think there's still a continued ongoing fear and ongoing stigma about psychotic disorder because of that. Like people who have delusions and hallucinations, it's not just a thing we say, they genuinely are far more of a risk themselves than anyone else. And it's important to not stop having that image in their head, because it harms both, the general population's view of mental illness, but also how the people with schizophrenia and psychotic disorder feel.
Absolutely.
And I think, sorry, I've got strong, I've got opinions on this. The other ones I think what I've been hitting on earlier, that not all psychotic experiences are schizophrenia or even a symptom of schizophrenia. So my entire field, a vast majority of people I screen who have a psychotic experience in childhood or adolescent never go on to develop a psychotic disorder, but they do show an increased risk for things like depression or anxiety. So it's more a marker of mental ill health. And there's also like a lot of people who lose a loved one experience grief hallucination. It's like we think about a third of people who lose a close loved one have it, which is they hear their voice, so they feel they see them, something like that. And then long distance runners also who push their bodies to quite extremes, something like 80% of them experience some forms of hallucination. So
that is not
fascinating.
I did not know that.
So it's like these symptoms aren't some aberrant thing that's something wrong with it's something wrong with their brain or something wrong about them. It's something our brains are capable of doing, but most people have control over their reality, so they're not able to not control it, whereas people with hallucinations do lose that capacity. So they're part of what everyone else is experiencing, not some aberrant group, which I think they can often get isolated as.
Absolutely. And I think the one word you mentioned that really kind of resonated with me is stigma. I think there is a lot of stigma, and I think that we do, almost as psychologists or budding psychologists in my case, have a duty to kind of inform people and make sure that there is the understanding around what the issue is, what the mental health difficulty is, and how it may manifest itself, and just kind of help people understand rather than anything else. So thank you so much for that as well. I'm extremely grateful for your time, and I have certainly learned a lot from this conversation. And I'm sure anyone viewing the video will too. So once again, thank you for sharing your knowledge. And to our viewers, let us know if you have learned something new and if there is anything that you found particularly interesting. And thank you for taking the time to watch the video. Feel free to share it. And that's it from me. So wishing you all a lovely week.